Welcome to the Hospital Medicine Unplugged podcast. Today we are undertaking a comprehensive physician-to-physician deep dive into the modern perspectives on endovascular and graft infection management.
Right.
Our mission today is to rigorously synthesize the recent data. We're explicitly focusing on the latest American Heart Association scientific statements.
And the joint guidelines.
Exactly, the joint guidelines from the European Association for Cardiothoracic Surgery and the Society of Thoracic Surgeons. Our goal is to translate these extensive, highly technical documents into actionable clinical insights that you can directly apply when managing complex patients on the wards.
Because these cases are incredibly challenging.
They really are.
Yeah.
We will be meticulously examining the baseline epidemiology of these infections, the profoundly shifting microbiological landscape, the highly controversial role of anticoagulation in septic thrombophlebitis, and the massive updates we are seeing in diagnostic imaging modalities.
To set the analytical framework for our discussion, we have to recognize that the management of endovascular infections has fundamentally shifted over the last decade. We are no longer simply dealing with acute, florid presentations of overt sepsis that are easily recognized at the bedside.
Right, the classic textbook presentations.
Exactly. Instead, we are increasingly encountering indolent biofilm-mediated pathologies that actively evade our traditional diagnostic algorithms. And they demonstrate terrifying resistance to standard empiric antimicrobial regimens.
I mean, it's a completely different clinical entity now.
It is. By exploring the deep pathophysiological why behind these updated guidelines, we can better equip ourselves to manage the immense clinical complexity these patients present with. We need to dissect the anatomical vulnerabilities of specific grafts, the molecular mechanisms of bacterial adherence, and the highly sophisticated imaging criteria now strictly required to establish a definitive diagnosis before catastrophic irreversible complications occur.
Okay, let's unpack this by starting with the epidemiology and the sheer scope of the endovascular infections we are currently seeing in our daily practice. When we look at the core data for vascular grafts, the baseline incidence of vascular graft infections occurs in 0.5 to 6% of all vascular reconstructive procedures.
Which is a significant number when you look at the sheer volume of these surgeries.
Absolutely. And what immediately stands out in the literature, and what we certainly see reflected on the floors, is that extracavitary infections significantly outpace intracavitary infections. I want to delve into the anatomical rationale here.
Sure.
We're seeing a much higher burden of disease in peripheral bypasses, like aortobifemoral or femoropopliteal grafts, compared to intracavitary grafts confined entirely within the abdomen or thorax. Why are these peripheral surgical sites demonstrating such a disproportionate vulnerability?
Well, the discrepancy between extracavitary and intracavitary infection rates is fundamentally rooted in a combination of profound anatomical and procedural vulnerabilities. Let us consider the typical patient receiving an extracavitary graft.
Like a femoropopliteal bypass.
Precisely. These surgical incisions, particularly those involving the groin, are immediately adjacent to anatomical areas heavily colonized by diverse regional flora. This includes robust populations of gram-positive cocci and various highly virulent gram-negative bacilli. The groin it's a notoriously challenging anatomical region to keep sterile post-operatively.
Just due to the mechanics of the area.
Right, due to sheer mechanical friction from ambulation, the accumulation of moisture, and its intimate proximity to the perineum. Furthermore, peripheral grafts are almost exclusively placed in patients with severe advanced peripheral arterial disease.
So they already have compromised tissue beds.
Exactly. These individuals can currently suffer from poorly controlled diabetes mellitus, profound microvascular ischemia, and subsequent severely impaired wound healing. When a superficial surgical site infection inevitably develops in these ischemic limbs, the contiguous spread of pathogens down to the underlying synthetic graft material is almost unavoidable.
Whereas intracavitary grafts are a different story.
They are. Intracavitary grafts, while surgically far more complex and physiologically demanding to place, are enclosed within sterile body cavities. These internal cavities possess a much more robust local blood supply. This enhances host immune surveillance via rapid neutrophil mobilization and facilitates much better initial healing of the surgical bed, provided there is no catastrophic intraoperative contamination.
I want to look specifically at endovascular devices, because the incidence here ranges from 0.2 to 5%, and the data presents a critical anatomical dichotomy that we need to understand.
The TEVAR versus EVAR data.
Yes. When we contrast thoracic endovascular aortic repair, or TEVAR, which carries a staggering infection rate of up to 5%, with endovascular abdominal aortic repair, which hovers around approximately 1%, we see a massive difference in infectious risk for what is ostensibly a very similar endovascular technique. From a clinical reasoning perspective, what is driving this immense gap?
What's fascinating here is the distinct anatomical and hemodynamic differences between the thoracic and abdominal aorta that predispose TEVAR to a significantly higher infectious burden. We must visualize the regional anatomy. The descending thoracic aorta lies in immediate, intimate physical proximity to the esophagus and the bronchial tree.
That structural relationship is key.
It's the entire driver of the risk. A significant proportion of TEVAR procedures are performed emergently or urgently for highly destructive pathologies, like complicated type B aortic dissections or traumatic aortic transections following severe deceleration injuries, or even rapidly expanding mycotic thoracic aneurysms.
So the environment is already highly inflamed and traumatized.
Right, and the sheer physical size and rigidity of the delivery systems required for these massive thoracic stent grafts can cause substantial, unavoidable endothelial trauma during deployment. Furthermore, the thoracic aorta is subject to intense, highly pulsatile hemodynamic shear stress with every single cardiac cycle.
Much more so than the abdominal aorta.
Exactly. Over time, even microscopic perforations, or the slow, insidious erosion of the rigid stent graft against the adjacent soft tissue of the esophageal wall, can lead to the formation of an aortoesophageal fistula. This results in the catastrophic polymicrobial seeding of the synthetic graft directly from the heavily colonized gastrointestinal tract. Abdominal endografts, while facing their own unique anatomical challenges, do not share this exact high-risk contiguous relationship with the esophagus, which partially explains the marked discrepancy in their respective long-term infection rates.
The narrative of device complexity becomes even more critical when we examine cardiac implantable electronic devices. The data shows that CIED infections have more than doubled. They've risen from 1.45% in the year 2000 to 3.41% in the year 2012.
That is a staggering jump.
It really is. We are obviously treating an increasingly frail, highly comorbid, aging demographic. But beyond just advancing patient age, we are implanting vastly more complex hardware. We have transitioned away from simple single-chamber pacemakers to highly complex biventricular cardiac resynchronization therapy defibrillators. These involve multiple intravascular leads and significantly larger generator pockets. How exactly does this increased physical hardware translate into an exponentially higher infection risk?
The physical footprint of these modern devices cannot be overstated when considering infectious risk. Each additional transvenous lead represents an exponential increase in the absolute surface area of foreign synthetic material introduced directly into the central bloodstream.
And that material is just a magnet for bacteria.
It acts as an ideal inert nidus for initial bacterial adherence. Furthermore, a larger, more complex generator requires the creation of a much larger surgical pocket in the prepectoral fascia. This translates directly to more extensive localized tissue disruption, an inherently increased risk of post-operative hematoma formation, and a higher probability of localized ischemic tissue necrosis along the wound margins.
All of which impairs localized healing.
Exactly. All of these factors combine to provide a perfect, nutrient-rich culture medium for opportunistic pathogens. Furthermore, the updated guidelines highlight a highly critical metric that we must memorize. Early reintervention is the absolute strongest independent risk factor for CIED infection.
That's a crucial point for floor management.
It is paramount. Every single time that surgical pocket is reopened, whether for a complex lead revision, a routine generator change due to battery depletion, or an urgent hematoma evacuation, the risk of introducing virulent skin flora multiplies exponentially. The fibrous, collagenous capsule that naturally forms around a mature device pocket is essentially a vascular.
So systemic therapies can't reach it.
Precisely. Once bacteria are introduced into that specific enclosed space during a reintervention, systemic immune cells and intravenously administered prophylactic antibiotics have extremely poor, almost negligible penetration into the area.
That brings us to a crucial piece of index hospitalization data that every physician managing these patients postoperatively needs to internalize. The guidelines heavily emphasize that any documented bacteremia during the index hospitalization for the initial reconstructive repair increases the risk of subsequent graft infection by a staggering 4.2-fold.
A 4.2-fold increase?
Yes. Consider a patient recovering on the surgical ward from an aortobifemoral bypass. If they develop a transient bacteremia from a routine ward complication, say a catheter-associated urinary tract infection or a central line-associated bloodstream infection, this is not just an isolated infectious event to be treated with a short course of targeted antibiotics and forgotten.
No, absolutely not.
That transient bacteremic shower can directly seed the freshly implanted, completely unendothelialized synthetic graft. It sets the stage for a devastating, deep-seated infection that might not clinically manifest until months or even years later.
This specific point demands a profound change in our clinical vigilance on the wards. When a prosthetic graft or a complex endovascular device is deployed, it immediately begins a highly complex, highly vulnerable process of host incorporation. This involves immediate fibrin deposition, the recruitment of fibroblasts, and eventual slow endothelialization.
But it takes time.
It takes significant time. In the immediate weeks following deployment, this synthetic material is completely naked and entirely exposed to the systemic bloodstream. If a patient experiences even a low-grade transient bacteremia from a seemingly benign source, circulating pathogens can adhere directly to the dacron or PTFE material. Because the synthetic graft completely lacks an intrinsic capillary network, local phagocytic function at the graft surface is essentially zero.
So even a minor inoculum is dangerous.
Exactly. A very small inoculum of bacteria can attach, survive the initial shear forces of the bloodstream, and slowly begin forming a highly protective biofilm. Therefore, if your postoperative patient spikes a fever on post-op day 4 and grows an organism from their urine or sputum, you must approach their ongoing management with the absolute understanding that their newly implanted aortic graft or their transvenous CIED lid is at immediate, imminent risk of hematogenous seeding.
This seamlessly brings us to the shifting microbiological landscape we are currently facing, which heavily dictates our initial empiric management strategies. When we look closely at the microbiology of vascular graft infections, gram-positive cocci absolutely dominate the clinical picture. They account for at least 2/3 of all documented infections.
Which is consistent with historical data.
It is. But the crucial epidemiological shift we need to dissect for our peers is that coagulase-negative staph has now conclusively surpassed staphylococcus as the single most common offending pathogen. We are fundamentally moving away from the classic fulminant presentations of acute sepsis and entering a highly frustrating era of incredibly indolent, insidious device infections. Walk us through the exact pathophysiology of why this shift is occurring and how it changes the clinical presentation.
The displacement of staphylococcus by coagulase-negative staph as the primary pathogen in vascular graft infections is a masterclass in bacterial evolution and opportunistic pathogenesis. Coagulase-negative staph, particularly Staphylococcus epidermidis, are ubiquitous commensal colonizers of the human skin flora.
They are everywhere.
Everywhere. Their primary weapon is not the aggressive production of tissue-destroying exotoxins that we classically see with staphylococcus, but rather their profound intrinsic ability to produce a highly viscous extracellular polymeric substance, commonly known as slime. This substance facilitates incredibly robust biofilm formation.
And that biofilm changes everything about how we treat them.
It fundamentally alters the local pharmacokinetics. Once these organisms adhere to the inert synthetic surface of a vascular graft, they rapidly encase themselves in this dense glycocalyx matrix. This mature biofilm acts as an impenetrable physical and chemical barrier to both migrating host neutrophils and systemically administered antibiotics. The bacteria residing within the deepest, most hypoxic layers of the biofilm downregulate their metabolic activity, entering a highly persistent dormant state.
Which renders cell wall active agents basically useless.
Precisely. Because beta-lactam antibiotics and many other standard antimicrobial classes absolutely require active bacterial cell wall synthesis and cellular division to be bactericidal, these dormant organisms become highly recalcitrant to therapy. This specific mechanism perfectly explains why patients with coagulase-negative staph graft infections frequently present without overt systemic toxicity.
They might not even have a fever.
Exactly. They present without soaring fevers, with completely normal white blood cell counts, and only complain of vague, slowly progressive symptoms like localized paragraft pain, persistent fatigue, or a slow-growing pseudoaneurysm that develops over the course of several months or even years.
Yet when we do encounter staphylococcus, particularly MRSA, the clinical trajectory is drastically, almost violently different. The incidence of MRSA infections is increasing at an alarming rate across all endovascular device categories. The data strictly and unequivocally correlates MRSA with drastically worse clinical outcomes.
The mortality data is truly sobering.
It really is, and we will delve into those specific numbers later in the discussion. We often see patients presenting with highly virulent tissue destruction that compromises the anastomotic suture lines much faster than other organisms, leading to catastrophic, often fatal hemorrhagic presentations. What specific virulence factors make MRSA so devastating in the context of a synthetic graft?
While coagulase-negative staph relies heavily on metabolic stealth and physical evasion, MRSA relies on overwhelming, aggressive biochemical warfare. MRSA produces a myriad of highly potent exotoxins, hemolysins, and proteases that actively dissolve and liquefy the host tissues immediately surrounding the synthetic graft.
It's actively destroying the host architecture.
It is liquefying the anastomosis. When MRSA infects a delicate vascular anastomosis, these proteases rapidly degrade the elastin and collagen of the native arterial wall. This direct enzymatic destruction rapidly precipitates acute anastomotic dehiscence and the subsequent formation of a highly unstable pseudoaneurysm, which is prone to sudden catastrophic rupture.
Which presents a surgical nightmare.
It leaves very little time for the multidisciplinary team to stabilize the patient, perform advanced imaging, and formulate a highly complex surgical reconstruction plan. Furthermore, the inherent genetic resistance of MRSA to all beta-lactam antibiotics forces us to rely on alternative agents like vancomycin or daptomycin.
And tissue penetration becomes a limiting factor.
Exactly. While these agents are generally effective in clearing the bloodstream, they often struggle to achieve the high minimum bactericidal concentrations required deep within the infected, highly necrotic, poorly perfused paragraft tissues. This leads to frequent clinical failures and the absolute necessity for massive surgical debridement.
While gram-positive organisms dominate, we must maintain a very high index of suspicion for gram-negative and rare pathogens, which present their own unique, highly complex clinical challenges. The data shows that Pseudomonas aeruginosa causes at least 10% of these infections.
And Pseudomonas is incredibly difficult to eradicate.
Completely. When Pseudomonas establishes itself in a vascular graft, usually in the setting of an extracavitary groin incision that is broken down, its intrinsic multi-drug resistance mechanisms and rapid elaboration of tissue-destroying elastases make graft salvage nearly impossible. We also have to consider mycotic aneurysms, where Salmonella species remain critically important, especially in the setting of native atherosclerotic aneurysms.
Even though overall incidences drop.
Right. Their overall population prevalence has fortunately declined alongside modern advances in commercial food safety, but the clinical entity is still highly relevant.
It is, because Salmonella possesses a highly specific, unique biological tropism for the diseased vascular endothelium. If we consider a patient with an extensive, highly calcified atherosclerotic plaque burden in their abdominal aorta, a transient Salmonella bacteremia, often following a seemingly mild, self-limiting episode of gastroenteritis, can result in the bacteria directly invading the vulnerable vasa vasorum of the diseased aorta.
They seek out that damaged tissue.
They preferentially seed the lipid-rich necrotic core of the atherosclerotic plaque. This initiates an intense localized inflammatory response, leading to a rapidly expanding, highly friable mycotic aneurysm that is incredibly prone to spontaneous fatal rupture. And while we are deeply discussing native aortic infections, we must explicitly remind our peers to keep rare but widely recognized, highly destructive pathogens on their differential diagnosis.
You're referring to the atypical organisms.
Specifically, Listeria monocytogenes and Mycobacterium tuberculosis must be continuously considered. Listeria monocytogenes can cause devastating mycotic aneurysms, particularly in much older patients, those on chronic immunosuppressive therapies or those with underlying cellular immune defects.
And tuberculosis can present as a vascular infection as well.
Mycobacterium tuberculosis, while increasingly rare in developed nations, can still cause highly complex tuberculous mycotic aneurysms. This typically occurs through contiguous direct spread from adjacent case-eating mediastinal or retroperitoneal lymph nodes, or via hematogenous miliary seeding. These specifically require highly complex, multi-drug anti-mycobacterial regimens for extended durations of up to 12 to 18 months, absolutely alongside radical surgical debridement.
That perfectly underscores the absolute necessity for broad, meticulously detailed clinical reasoning on the wards. Moving from the aorta and peripheral arterial grafts to specific, highly complex venous clinical syndromes, the recent literature provides critical updates on Lemierre syndrome and pyelophlebitis. Let us visualize a patient presenting to the emergency department.
The classic presentation.
Yes, the classic presentation of Lemierre syndrome remains a highly specific, very recognizable triad. Acute pharyngotonsillitis, subsequent internal jugular vein thrombosis, and distant septic emboli, with bilateral pulmonary involvement in the form of rapidly cavitating lung lesions, being the absolute most common metastatic site. Historically, when we see this triad, it has been almost exclusively associated with the anaerobic organism Fusobacterium necrophorum.
The precise pathophysiology of classic Lemierre syndrome is a fascinating cascade of highly localized anatomical destruction. Fusobacterium necrophorum is a normal, obligate anaerobic inhabitant of the healthy human oropharynx. The initial insult is typically a primary viral pharyngitis, such as Epstein-Barr virus.
So the viral infection paves the way.
Exactly. This viral infection damages the epithelial mucosal defense barriers, allowing the commensal Fusobacterium to deeply invade the highly vascularized lateral pharyngeal space. From there, it triggers an intense, overwhelming, localized inflammatory response that directly precipitates acute septic thrombophlebitis of the immediately adjacent internal jugular vein.
And then the embolization begins.
The heavily infected, highly friable venous thrombus then continuously sheds microscopic septic emboli into the venous return through the right side of the heart and directly out into the pulmonary capillary bed. This results in bilateral, rapidly progressive cavitary pneumonia, massive empyema formation, and acute hypoxemic respiratory failure that frequently requires mechanical ventilation.
But the critical, highly alarming update for our daily practice on the wards is the severe epidemiological shift we are currently observing. While Fusobacterium remains the classic etiology, there is a prominent, rapidly emerging role of MRSA in causing classic Lemierre syndrome.
Which is a dramatic paradigm shift.
It fundamentally is. A young, previously healthy patient presenting with the classic triad of sore throat, neck swelling, and cavitary lung lesions can no longer be safely assumed to merely have an anaerobic infection. We must deeply consider the prevailing hypothesis as to exactly why this incidence has seemingly increased over the past decade. A highly plausible, heavily debated theory being discussed in the recent literature suggests that our own intense system-wide efforts to decrease antibiotic prescribing for routine upper respiratory infections may be inadvertently driving this rising incidence of aggressive superinfections.
It is a profound clinical paradox that we must carefully navigate. The global antibiotic stewardship movement has been incredibly successful, and rightly so, in reducing the unnecessary use of agents like azithromycin and amoxicillin for simple viral pharyngitis. However, this broad population-level reduction in empiric antibiotic use means that early opportunistic superinfecting bacterial pathogens, which might previously have been inadvertently eradicated by these unnecessary empiric prescriptions, are now allowed to proliferate completely unchecked in the damaged oropharynx.
The mucosal barrier is down, and there's no antibiotic suppression.
Precisely. As a result, organisms like Fusobacterium and increasingly highly virulent community-acquired MRSA are aggressively exploiting the initial viral mucosal damage. They invade the deep parapharyngeal spaces and establish full-blown, life-threatening septic thrombophlebitis before the patient ever returns to seek further medical attention. The rapid emergence of MRSA as a causative agent in Lemierre syndrome completely alters our initial empiric antibiotic strategy on the floors.
We have to broaden our initial coverage immediately.
We can no longer simply prescribe high-dose intravenous penicillin and metronidazole and assume adequate coverage. We must immediately institute highly aggressive, targeted MRSA coverage with agents like vancomycin or linezolid in these acutely ill, highly unstable patients.
This concept directly translates to the intra-abdominal cavity when we discuss the abdominal variant pyelophlebitis. Pyelophlebitis is effectively defined in the modern updated literature as the abdominal variant of Lemierre syndrome, precisely when it is caused by Fusobacterium species. However, instead of the oropharynx and the internal jugular vein, the primary infectious source is typically a severe intra-abdominal infection.
Like acute microperforated diverticulitis.
Exactly, or suppurative appendicitis leading directly to septic thrombophlebitis of the portal and splenic venous systems. Diagnostically on the floors, these patients present a highly confusing, incredibly vague clinical picture. They complain of diffuse abdominal pain, they have soaring, spiking fevers, profound rigors, and potentially new-onset jaundice or severe transaminitis.
And the timeline is often delayed.
Often this presentation occurs long after the initial seemingly mild inciting intra-abdominal event seemed to have completely resolved with standard oral antibiotics.
Phlebitis is notoriously difficult to diagnose early in its clinical course because the initial intra-abdominal nidus, such as a localized microperforated diverticulum, may be entirely subclinical by the time the massive propagating portal venous thrombosis becomes symptomatic. The Fusobacterium, or mixed enteric flora, travel directly via the mesenteric venous drainage directly into the main portal system, instigating an intense, highly localized venous thrombosis,
which rapidly propagates toward the liver.
As the highly infected thrombus propagates proximally toward the liver, it not only causes acute portal hypertension and potentially devastating mesenteric bowel ischemia, but it continuously showers the highly vascular hepatic parenchyma with bacteria. This frequently results in the formation of multiple, complex, highly loculated pyogenic litter abscesses,
making the diagnostic imaging on the wards quite challenging.
The diagnostic delay on the wards is often significant because routine right upper quadrant abdominal ultrasounds may entirely miss a developing portal vein thrombus that is heavily obscured by overlying bowel gas. It strictly requires a high-quality, contrast-enhanced CT scan, precisely timed in the portal venous phase, to definitively visualize the defining central filling defect within the portal vein, accompanied by the characteristic, intense inflammatory fat stranding surrounding the vessel.
This perfectly leads us into the diagnostic revolution we are currently witnessing in the management of endovascular infections, specifically regarding our baseline laboratory evaluations and the massive, highly impactful paradigm shifts in advanced imaging modalities. Starting with the laboratory evaluation, the baseline data shows that blood cultures are positive in roughly 70 to 74% of all vascular graft and mycotic aneurysm cases,
leaving a large percentage culture negative.
Right. Well, that 70 to 74% leaves a highly significant margin of frustrating culture-negative cases. It underscores the absolute necessity of drawing multiple, appropriately timed, large-volume blood cultures strictly prior to the initiation of any broad-spectrum antimicrobial therapy. Here's where it gets really interesting, though. A definitive, irrefutable microbiological diagnosis absolutely requires direct microscopic visualization and culture recovery from deep tissue biopsy or explanted synthetic graft material. Swabs are vastly, unequivocally inferior, even when they are meticulously collected under strict sterile technique in the operating room. I want to drill down on why exactly a swab from a purulent surgical field is so clinically useless compared to a piece of the actual graft.
The widespread reliance on simple swab cultures is a pervasive, highly detrimental clinical error that significantly compromises patient outcomes and drives prolonged, ineffective antibiotic courses. When a surgeon opens an actively infected vascular graft field and merely swabs the surrounding liquid purulence or lightly swabs the surface of the synthetic device, they are overwhelmingly likely to sample superficially colonizing organisms.
Or just benign wound contaminants.
Precisely. Or merely the planktonic bacteria floating in the fluid. They completely miss the deep, heavily embedded, true pathogenic organism that is aggressively driving the infection from within the mature biofilm. Furthermore, the sheer physical volume of material captured by a standard swab is inherently insufficient for the microbiology lab to perform comprehensive fungal and mycobacterial cultures alongside standard aerobic and anaerobic processing.
So you need the actual tissue.
The updated guidelines are now absolutely unequivocal. You must send actual chunks of the necrotic paragraft tissue, the explanted synthetic decrin or PTFE material itself, or the excised, highly infected native arterial wall. Only by vigorously mechanically disrupting the physical biofilm attached to the explanted tissue in the laboratory, often through advanced techniques like sonication, can we accurately isolate the true causative organism, force it out of its dormant state, and obtain highly reliable, clinically actionable antimicrobial susceptibility profiles.
I want to look closely at the shift in our imaging protocols, because this is where the diagnostic landscape changes completely. Historically, we relied almost exclusively on standard contrast-enhanced CT imaging, but we are now firmly in the era of 18F FDG PT-CT. The rapid emergence of PTT has completely revolutionized our diagnostic algorithm for these highly complex infections. The recent data shows that utilizing the specific FDG uptake pattern interpretation yields a remarkable 94% sensitivity and an 81% specificity.
The sensitivity is unparalleled.
Even more critically, for complex clinical decision-making on the wards, a definitively negative PCT possesses a 100% negative predictive value. This makes it an absolutely pristine, unparalleled rule-out tool when you have a patient with vague constitutional symptoms, unexplained inflammatory markers, and you need to definitively, confidently exclude a deep vascular graft infection before discharging them.
The underlying physics and specific cellular physiology behind 18F-FDG PTCT make it uniquely, exquisitely suited for diagnosing this specific pathology. We are utilizing a highly specialized radio-labeled glucose analog, fluorodeoxyglucose, which is aggressively taken up by highly metabolically active cells. In the exact context of a severe synthetic graft infection, massively activated neutrophils and heavily recruited macrophages actively migrating to the site of the infected graft consume this glucose analog at exponentially higher rates than normal, resting surrounding tissue.
It essentially lights up the active inflammation.
It does. However, the true advancement heavily emphasized in the current guidelines is not just the mere use of PCT, but the highly specific interpretation method utilized by the reading radiologist. Historically, radiologists relied almost exclusively on simple quantitative intensity metrics, like the maximum standardized uptake value. But we now definitively know that assessing the exact anatomical pattern of uptake is far superior and far more clinically relevant.
The pattern is what distinguishes true infection.
Exactly. A focal, highly heterogeneous, intensely localized uptake pattern is incredibly specific for true active bacterial infection. Conversely, a mild, diffuse, highly homogeneous uptake extending uniformly along the entire length of the synthetic graft is often merely reflective of sterile, expected chronic foreign body inflammatory reactions. It is the specific pattern, not just the raw brightness, that aggressively drives that remarkable 94% sensitivity.
But we absolutely must address the massive, highly frustrating clinical pitfall associated with this advanced technology on the wards. The literature highlights a critical, highly concerning issue regarding standardized radiological reporting. Currently, less than half of all generated PTCT reports meet standardized reporting criteria.
That is a significant operational barrier.
This profound variability in radiological reporting significantly lowers the practical, real-world clinical accuracy of the test when utilized outside of highly specialized major academic referral centers. If the reading radiologist does not specifically explicitly comment on the exact pattern of uptake, the distinct presence or absence of paragraph fluid collections, and the exact anatomical correlation using the non-contrast CT portion of the study, the clinician is left with an incredibly ambiguous, functionally useless report that cannot safely or confidently guide a high-stakes, potentially morbid surgical intervention.
Exactly. This severe inconsistency forces us, as clinicians, to strictly adhere to the optimal, stepwise imaging algorithm rigorously recommended by the recent consensus guidelines, and often requires us to directly call the reading room to review the images ourselves. Step 1 remains a high-quality CT, or CTA, as the initial, absolute required screening modality.
Because it gives us the raw anatomical layout.
It provides exquisite, unparalleled anatomical detail, reliably identifies gross paragraph fluid collections, visualizes expanding pseudoaneurysms, and definitively highlights the presence of ectopic paragraph gas, which is highly specific for active infection if found late in the postoperative course. However, when the initial CTA is equivocal or completely negative despite a high clinical suspicion, we immediately move to step 2, where postoperative timing is absolutely critical.
The 4-month window.
Yes. If the patient is less than 4 months post-surgery, utilizing a PCT is actually strictly contraindicated due to the massive, sterile, expected postoperative inflammatory response that will invariably cause intense, highly confusing false positive FDG uptake. In this specific early postoperative window less than 4 months, you must utilize 99 millitc labeled white blood cell scintigraphy,
which tracks actual neutrophil migration.
By physically drawing the patient's own leukocytes, carefully radiolabeling them in the lab, and re-injecting them, we can see exactly where active acute neutrophil migration is currently occurring, providing vastly higher specificity in the early, highly inflammatory surgical phase. Conversely, if the patient is more than 4 months out from their index operation, the sterile inflammation has subsided, and we can safely and highly effectively proceed to PTCT, capitalizing fully on its unparalleled 94% sensitivity. Additionally, indium-labeled white blood cell studies remain a highly helpful, deeply reliable adjunctive modality for specific endovascular device infections when advanced PTCT is unavailable or the results remain equivocal.
Shifting to the specific imaging of cardiac implantable electronic devices, the initial standard evaluation strictly remains transesophageal echocardiography, or TEE. The spatial resolution of a TEE for clearly visualizing highly mobile lid vegetations and assessing for destructive valvular involvement is clinically indispensable. However, we must strongly, unequivocally emphasize to our peers that an initial, completely negative TEE for macroscopic vegetation does absolutely not rule out a devastating CIED infection.
It is a common misconception that a clean TEE means no infection.
Exactly. If the clinical suspicion remains high, say, a patient with persistent Staph aureus bacteremia and a pacemaker repeated TE imaging a week later, or immediately transitioning directly to a PCT to aggressively look for intense metabolic activity along the extravascular portion of the leads or within the generator pocket, is highly valuable and strictly recommended by the guidelines.
The fundamental limitation of TEE lies entirely in its strict dependence on the physical, macroscopic size of the vegetation. Early in the pathogenesis of a highly aggressive CIE-led infection, the bacteria rapidly form a microscopic biofilm that simply does not possess the massive macroscopic physical volume strictly required to be reliably resolved by echocardiographic sound waves.
The ultrasound waves literally pass right over it.
Furthermore, the heavy, blinding metallic artifact produced by the massive titanium leads themselves can easily obscure tiny, early vegetations attached directly to the delicate atrial or ventricular endothelium. Therefore, if a patient has persistent, highly concerning staphylococcal bacteremia and a completely normal, pristine TEE, the active infection is almost certainly still present somewhere on the hardware, just not yet visibly large enough to reflect the ultrasound waves. This is precisely where 18F-FDG-PECC is proving absolutely invaluable for complex CIEDs. It reliably detects the intense metabolic activity of the microscopic localized inflammatory response long before a massive macroscopic vegetation physically forms and threatens to embolize.
To bring all of these highly complex diagnostic variables together into a cohesive, actionable framework on the wards, the updated guidelines have formally introduced the MAGIC criteria, the Management of Aortic Graft Infection Collaboration criteria. Similar to the highly validated Duke criteria for infective endocarditis, the MAGIC criteria heavily standardize our definitive diagnoses by establishing strict major and minor criteria meticulously categorized across clinical, radiological, and laboratory domains.
It forces a structured diagnostic approach.
It does. This standardized framework actively prevents clinicians from heavily weighing a single anomalous, potentially misleading finding. It strictly requires a holistic, comprehensive synthesis of explicit intraoperative findings, exact PTCT localized uptake patterns, and precise speciation of deep tissue cultures to definitively categorize an infection as proven, strongly suspected, or firmly rejected.
The widespread implementation of the MAGIC criteria represents a monumental, desperately needed step forward in establishing rigorous diagnostic certainty. For instance, finding ectopic paragraft gas on a CTA more than 7 weeks postoperatively is correctly classified as a major radiological criterion, precisely because normal, sterile postoperative gas should have completely resorbed into the surrounding tissue by that explicit time point.
Whereas a single blood culture might just be a minor criterion.
Exactly. A single positive blood culture for a common, highly prevalent skin flora organism would only be appropriately classified as a minor laboratory criterion, whereas the definitive isolation of a typical virulent pathogen directly from mechanically sonicated explanted paragraft tissue is a massive major criterion. By aggressively forcing clinicians to objectively tally these specific criteria, we effectively eliminate the immense subjective bias and clinical guesswork that historically plagued the diagnosis of these highly complex infections. This ensures that vulnerable patients only undergo massive, life-altering, highly morbid extra-anatomic bypass surgeries when the diagnosis is robustly, definitively supported by overwhelming standardized evidence.
This precise diagnostic certainty is strictly, absolutely required, precisely because the management strategies we must employ are incredibly grueling and highly toxic for the patient. Let us transition to the strict antimicrobial guidelines. For definitively proven vascular grafts, the absolute minimum duration is an exhaustive 6 weeks of highly directed, high-dose intravenous therapy, strictly provided that the deep tissue culture is positive and susceptibilities are known.
6 weeks is the baseline.
Right. However, we must aggressively extend this powerful therapy to a full continuous 6 months in the explicit presence of frank intraoperative purulence, the highly dreaded isolation of MRSA, the presence of any severely multi-drug-resistant organisms, or infections aggressively driven by invasive Candida species.
The deep pathophysiological rationale behind drastically extending targeted therapy to a profound 6 months for these specific, highly concerning high-risk scenarios is rooted entirely in the severe physical limits of deep antimicrobial penetration. In the presence of frank liquefactive intraoperative purulence, the highly delicate local tissue architecture is entirely necrotic, meaning reliable drug delivery via the destroyed local capillary bed is virtually non-existent.
The drug just physically cannot reach the target.
It can't. MRSA, extensively multi-drug-resistant gram-negative rods, and invasive Candida species are biologically notorious for generating incredibly dense, highly resilient, incredibly thick biofilms. Standard 6-week courses are simply demonstrably inadequate to definitively sterilize these highly hostile, poorly perfused microenvironments. The massively extended 6-month course, which often involves a careful transition to highly bioavailable oral agents after the initial prolonged intravenous phase, aims to continuously, relentlessly suppress the residual dormant organisms that invariably survive the initial extensive surgical debridement. We must medically suppress these organisms until the host tissue can adequately granulate, establish a new capillary network, and physically, permanently wall off the remaining synthetic material.
The strategy differs heavily when we discuss CIED infections, where the strict antimicrobial durations are tied directly to the specific clinical manifestation and the exact timing of hardware extraction. If a patient presents to the clinic with a mere superficial pocket site erosion, completely without deeper purulence, the guidelines recommend a remarkably short 7 days of targeted antibiotics, strictly following complete hardware extraction.
A very targeted, brief course.
If there's a frank, purulent pocket site infection extending deeper into the fascia, the required duration immediately increases to 10 days post-extraction. However, if the patient has tragically progressed to a sustained bloodstream infection or overt, highly destructive valvular infective endocarditis, we are absolutely committed to a full 4 to 6 weeks of high-dose parenteral treatment, strictly following the complete removal of the hardware.
These highly staggered, precisely calibrated durations brilliantly reflect the fundamentally different pathophysiological states of the infectious burden. A clean, superficial pocket erosion strictly without purulence heavily implies that the sterile, bulky device has simply physically eroded through the thinned, poorly vascularized dermis due to mechanical pressure, and the subsequent bacterial contamination is limited entirely to the superficial margins of the open wound. Rapidly extracting the device and providing a short, focused 7 days of therapy easily eradicates this highly localized contamination.
It hasn't reached the bloodstream yet.
Correct. Conversely, a sustained bloodstream infection unequivocally implies that the virulent organism has fundamentally, completely overcome the host's systemic innate defenses, successfully established deep intravascular vegetations on the leads or native valves, and is continuously aggressively seeding distant capillary beds throughout the body. Even after the massive physical nidus, the entire infected CIE system is surgically extracted, you absolutely must complete the traditional grueling 4 to 6 weeks of high-dose intravenous bactericidal therapy to thoroughly sterilize the widespread micrometastatic foci scattered silently throughout the pulmonary and systemic circulation.
And when we circle back to our discussion of Lemierre syndrome, the antimicrobial strategy requires an extensive 3 to 6 weeks of comprehensive high-dose therapy. This classically employs a powerful combination of intravenous metronidazole and a broad-spectrum beta-lactam antibiotic to aggressively cover the anaerobic Fusobacterium and the highly complex mixed oral flora. But as we deeply discussed regarding the terrifying shifting microbiology, early empiric MRSA coverage is now utterly, absolutely crucial for high-risk patients.
Identifying those high-risk patients early is vital.
This explicitly includes the undomiciled, the incarcerated active injection drug users, those who are HIV positive, and absolutely anyone with a recent prolonged hospitalization or significant prior broad-spectrum antibiotic exposure. We also need to carefully define the role of lifelong suppressive therapy, which is a frequent, difficult reality on the wards. We frequently encounter extremely frail octogenarian patients who possess a definitively infected aortic graft, but simply cannot biologically survive the massive physiological insult of a highly complex surgical explantation. In these specific, highly selected, vulnerable cohorts, we are frequently forced to commit them to lifelong oral suppressive therapy, precisely because complete device removal is biologically, functionally unfeasible.
Committing a patient to lifelong suppressive therapy is essentially a clinical concession of defeat regarding definitive curative intent. We are aiming instead entirely for long-term precarious symptom control. We are functionally accepting that the highly complex biofilm will permanently, inextricably reside on the synthetic graft until the patient expires.
It's a very delicate balancing act.
It is. The strict goal of the lifelong oral regimen, often utilizing highly bioavailable agents like oral doxycycline, trimethoprim, sulfamethoxazole, or low suppressive doses of oral beta-lactams, is to continuously maintain a steady serum antibiotic concentration just high enough to forcefully prevent the dormant, metabolically inactive biofilm bacteria from returning to a planktonic, rapidly dividing, highly virulent state. That state would immediately trigger overwhelming systemic sepsis, precipitate acute, fatal, and anastomotic rupture. It is an incredibly precarious, highly dangerous balancing act, constantly, daily risking the slow development of extensive multi-drug resistance and severe, highly morbid medication toxicities. But it tragically remains the only viable, clinically sound strategy when a frail, highly comorbid patient's immediate surgical mortality risk heavily approaches 100%.
Which perfectly sets the stage for discussing the monumental, heroic surgical interventions required when we do aggressively aim for a definitive cure. For deeply infected vascular grafts, the historical, unyielding gold standard has always been complete. Total graft excision, strictly followed by extensive extra-anatomic revascularization.
A massively invasive procedure.
This highly complex process involves opening the abdomen, removing the massively infected abdominal aortic graft entirely, meticulously sewing the highly friable native aortic stump shut, and then creating a massive, unnatural axillobifemoral bypass. This involves physically tunneling a new, sterile synthetic graft circutaneously down the side of the patient's torso from the axillary artery directly to the femoral arteries to somehow perfuse the ischemic legs. It is an incredibly morbid, anatomically extreme, highly destabilizing procedure. However, the updated guidelines now surprisingly support in situ reconstruction,
Which is a major shift from historical teaching.
This involves completely removing the heavily infected material, radically debriding the necrotic bed, and immediately placing a new conduit directly back into the infected anatomical bed. This relies on utilizing highly specialized cryopreserved arterial allografts, harvested venous autografts from the patient's own deep femoral veins, or advanced rifampin-bonded synthetic grafts. We're also seeing compelling data strongly suggesting that highly limited reconstruction, surgically removing only the focally infected segment rather than exploding the entire graft, is significantly associated with lower perioperative mortality than complete, total removal in highly selected, carefully imaged cases.
The rapid clinical shift towards embracing in situ reconstruction represents a profound, fundamental evolution in core surgical philosophy. Historically, traditional surgeons firmly believed placing any new material directly into an actively infected, heavily purulent field was a guaranteed immediate catastrophic failure. However, the long-term outcomes of extra-anatomic axillobifemoral bypasses were often utterly abysmal due to extremely high rates of devastating aortic stump blowout.
Where the closed aorta just ruptures.
Yes. This occurs where the highly inflamed, closed native aorta violently ruptures weeks later due to residual microscopic deep tissue infection, alongside the exceptionally high incidence of delayed subcutaneous graft thrombosis. By thoughtfully utilizing highly specialized biological conduits like cryopreserved cadaveric allografts or harvesting the patient's own deep veins, we are intentionally placing robust tissue that possesses deep intrinsic resistance to bacterial colonization directly into the exact anatomical position.
It brings its own healing capacity.
These biological conduits can actively, organically integrate with the host's immune system and establish a new capillary network, completely unlike inert dacron. Furthermore, the advent of highly advanced rifampin-bonded synthetic grafts allows for the slow, highly localized, sustained elution of massive concentrations of bactericidal antibiotics directly into the newly radically debrided surgical bed. This aggressively suppresses early bacterial adhesion while the new graft slowly incorporates.
And the limited reconstruction relies heavily on our imaging.
Exactly. The modern concept of limited reconstruction relies entirely, absolutely, on the exquisite precision of our modern PET-CT imaging. If we can definitively, unequivocally prove via PET-CT that the active metabolic infection is completely isolated to just one single limb of a bifurcated graft, we can dramatically reduce the surgical magnitude by only explanting that single limb. This strictly preserves the uninfected main aortic body and thereby significantly, demonstrably reduces the immediate, profound, operative mortality.
When we transition to the highly aggressive surgical management of CIED infections, the data is stark, and the consensus guidelines are completely, utterly unyielding. You must emphasize this constantly to your cardiology colleagues on the wards. Complete, total removal of all physical hardware is absolutely, undeniably mandatory for a definite CIED infection. You absolutely cannot leave retained, heavily infected leads behind in the vascular space and hope to simply suppress them with long-term antibiotics.
It never works.
Furthermore, Early extraction, strictly defined as performing the extraction within 7 days of the initial clinical diagnosis, drops the 1-year mortality rate by an astonishing, highly significant threefold. A threefold decrease in mortality simply by accelerating the extraction timeline and getting the patient to the lab faster. Percutaneous extraction utilizing highly specialized laser sheaths or advanced mechanical cutting tools is strongly, heavily preferred over massive open cardiovascular surgery, strictly unless the patient has a massive, highly mobile vegetation greater than 20 millimeters, or there is an explicit, independent clinical indication for concurrent open valvular surgery.
This specific point regarding extraction timing is absolutely paramount. That incredible threefold reduction in mortality by successfully extracting all hardware strictly within 7 days highlights the devastating, overwhelming systemic toll of allowing a high-grade active intravascular infection to smolder unchecked.
The inflammatory burden is immense.
Every single day, a heavily infected lead remains freely floating in the right atrium or right ventricle. It is continuously, massively seeding the delicate pulmonary microvasculature, driving a profound, highly destructive systemic inflammatory response and exponentially, aggressively increasing the risk of complete, irreversible tricuspid valve destruction. The core reason percutaneous extraction is vastly overwhelmingly preferred is due to the sheer massive physiological insult of open sternotomy and the absolute necessity of prolonged cardiopulmonary bypass required to surgically manually extract these leads.
But percutaneous extraction carries its own severe risks.
We must explicitly acknowledge that percutaneous extraction is not without extreme catastrophic risk. The older leads are often densely, heavily fibrous directly to the paper-thin wall of the superior vena cava. Utilizing a highly energetic laser sheath to slowly vaporize that dense scar tissue carries a very real, terrifying risk of catastrophic, fatal cava laceration. This specific high-stakes reality is precisely why the guidelines strictly, unequivocally mandate that these procedures be performed exclusively by a highly specialized, tightly coordinated multidisciplinary team. You absolutely need the specialized electrophysiologist performing the complex extraction, a highly skilled cardiovascular surgeon scrubbed and on immediate standby in a fully equipped hybrid operating room ready to perform an emergency crash sternotomy if the cava suddenly tears, alongside dedicated infectious disease specialists and advanced cardiac imaging specialists orchestrating the highly complex perioperative care.
So what does this all mean when we face these controversies on the floors? I want to address an immense, highly debated controversy that we frequently encounter on the medical wards. We frequently admit highly complex patients with severe Lemierre syndrome or aggressive biophlebitis, and the absolute most heated debate during our multidisciplinary rounds is exactly whether or not to start high-dose therapeutic anticoagulation for the infected venous thrombus.
It is the ultimate, highly frustrating clinical catch-22 that we face in hospital medicine. On one hand, you have a massive, rapidly propagating, highly infected thrombus located in the delicate internal jugular or the critical portal vein that is continuously acting as a massive reservoir for septic emboli, potentially threatening to completely occlude critical venous drainage and cause massive end organ failure. The underlying pathophysiological rationale for aggressive anticoagulation is to immediately halt the rapid propagation of this clot and allow the body's highly effective endogenous fibrinolytic system to slowly break down the dense nidus of infection.
But the bleeding risk is astronomical.
On the other hand, these are fundamentally septic, highly inflamed, incredibly fragile patients. In Lemierre syndrome, they often possess massive friable cavitary lung lesions that are exceptionally prone to massive fatal hemoptysis. In pylophlebitis, the acute portal hypertension can rapidly lead to highly unstable bleeding esophageal varices. Administering high-dose systemic therapeutic anticoagulation in the immediate setting of actively necrotic, highly vascularized, heavily infected tissues carries a terrifying, deeply concerning risk of precipitating a sudden fatal hemorrhage.
Let's look closely at the current, highly nuanced evidence navigating this massive dilemma. The recent literature suggests that careful anticoagulation is generally efficacious and surprisingly safe in these specific complex syndromes, and surprisingly, this includes the modern, carefully monitored use of DOACs. If initiated, the recommended duration is generally a standard 6 to 12 weeks, treating it effectively as a highly provoked deep vein thrombosis. However, the statistical nuance here is absolutely critical for our peers to understand.
The mortality data on this is striking.
The absolute largest, most comprehensive study conducted to date on this specific topic explicitly showed that the in-hospital mortality was 3.39% in the cohort that received therapeutic anticoagulation, versus 1.69% in the cohort that absolutely did not receive anticoagulation. Statistically, the calculated p-value was exactly 0.56, definitively meaning there was absolutely no statistically significant survival benefit to aggressively administering the anticoagulation.
That exact, highly frustrating statistical reality, the complete demonstrable absence of a clear mortality benefit, is exactly why this specific clinical decision remains so intensely controversial. You are actively, knowingly exposing the highly vulnerable patient to the known severe risks of major life-threatening bleeding without a guaranteed proven overall survival advantage. However, despite the stark lack of a clear mortality benefit, the updated guidelines still heavily, consistently recommend initiating anticoagulation strictly in the absence of absolute explicit contraindications.
Why push for it without a mortality benefit?
Because while it demonstrably may not alter the overall long-term mortality rate, it profoundly, significantly impacts the rate of severe, life-altering morbidity. The consensus experts actively argue that immediate anticoagulation is specifically highly warranted to prevent the catastrophic, irreversible extension of the highly infected thrombus directly into the delicate cerebral venous sinuses in Lemierre syndrome, or the complete, devastating cavernous transformation of the main portal vein in pylophlebitis. It is also strongly, heavily recommended in the face of persistent, unyielding bacteremia that completely refuses to clear despite optimal high-dose intravenous antibiotics, as the anticoagulation actively prevents new, dense fibrin deposition on the clot, slowly exposing the deeply embedded protected bacteria to the circulating antimicrobial agents. Therefore, the complex decision must be highly individualized on rounds, precisely balancing the severe risk of massive clot propagation against the specific patient's inherent baseline bleeding risk.
This somber, highly complex clinical reality naturally leads us to the grim prognosis and prevention data, which frankly remains terrifying, despite all of our incredible modern surgical and antimicrobial interventions. The sobering mortality data clearly states that an untreated intracavitary vascular graft infection carries a virtually 100% mortality rate. It is a uniformly, definitively fatal disease if tragically left to its natural destructive course.
The numbers are incredibly unforgiving.
Even when we intervene aggressively with massive resources, the immediate operative mortality for these massive, highly complex reconstructive surgeries ranges widely from 0 to 18%, heavily, entirely dependent on the patient's baseline physiological frailty and the exact anatomical complexity of the infected field. For peripheral extracavitary grafts, the major amputation rates remain deeply grim, ranging from 0 to 16%. If we specifically look at the one-year mortality for complex mycotic aneurysms and major vascular graft infections combined, we're looking at roughly 32 to 40% of our highly complex patients tragically dying within 12 months.
The long-term longitudinal tracking data is even more distressing for clinicians to review. When we track survival for major mycotic aneurysms and massive aortic infections, overall survival drops steeply and relentlessly over time. Only 49% of patients are alive at 1 year, dropping to 31% at 3 years, and a devastating, highly discouraging 23% at 5 years.
The physiological toll is just too great.
These surviving patients are enduring a monumental, highly destructive physiological insult. Even if they miraculously survive the initial profound septic shock and the massive, highly morbid surgical reconstruction, the profound, sustained systemic inflammatory state fundamentally aggressively accelerates their underlying baseline cardiovascular disease, leading directly to exceptionally high rates of late fatal myocardial infarctions and devastating strokes, and we must continuously, rigorously return to the intrinsic virulence of the pathogen. The data explicitly, strongly identifies MRSA as a massive, overwhelming, independent predictor of mortality, carrying an astonishing, terrifying adjusted odds ratio of 93.2.
That is an unbelievable odds ratio.
Let that massive statistical fact sink in for a moment. An odds ratio of 93.2. If your specific patient's synthetic graft is infected with MRSA, their probability of death is exponentially, massively magnified, precisely due to the highly aggressive, relentless tissue necrosis and the extreme, frequently insurmountable difficulty of achieving total microbial eradication deep within the heavily compromised surgical bed.
Given these horrific, deeply concerning prognostic statistics, absolute prevention at the time of initial implantation becomes paramount. Briefly covering highly advanced prophylactic strategies, the updated guidelines highly emphasize the specific use of antibacterial envelopes for initial CIE implantations in highly selected high-risk patients. These bioabsorbable envelopes, which are specifically engineered to slowly elute high concentrations of minocycline and rifampin directly into the highly vulnerable generator pocket over the first crucial weeks of tissue healing, have shown definitive, robust clinical benefit in heavily preventing initial bacterial colonization.
It acts as an active shield.
Exactly. They act as a crucial, highly effective adjunct, strictly alongside our standard, meticulously timed preoperative systemic intravenous antibiotics. We are fundamentally aggressively trying to win the infectious war before the highly resilient biofilm can ever establish its first microscopic beachhead on the titanium generator.
Exactly. The highly advanced TURX antibacterial envelope is a prime, brilliant example of engineering a localized, highly hostile microenvironment for opportunistic pathogens, precisely during the specific surgical window of maximum infectious vulnerability. By physically ensuring that the actual physical space immediately surrounding the newly implanted generator is deeply saturated with exceptionally high, localized concentrations of bactericidal agents that far, far exceed what could ever be safely achieved via standard systemic intravenous dosing, we drastically significantly reduce the chance that a single rogue staph organism inadvertently introduced from the patient's own dermis can adhere to the titanium generator and initiate rapid glycocalyx production. If we connect this to the bigger picture, synthesizing the core critical themes of this extensive, highly detailed deep dive, we are definitively witnessing a complete fundamental transformation in how we must manage these highly complex endovascular and graft infections on the wards. We must completely, immediately transition toward heavily utilizing advanced 18F FDG PACE-CT imaging, strictly with highly standardized, pattern-based interpretation to secure early, highly definitive diagnoses. We must deeply respect the terrifying, rapidly rising incidence of highly destructive MRSA and the stealthy, highly resilient biofilm-producing coagulase-negative staph. And above all, we must constantly, relentlessly advocate for the critical, life-saving push for early CIED hardware extraction, strictly within that crucial 7-day window, to drastically, significantly reduce catastrophic patient mortality.
It requires a completely coordinated, aggressive, multidisciplinary approach.
This raises an important question for the very near future of our clinical practice. As endovascular devices become increasingly highly integrated with the human cellular tissue, and as highly advanced anti-biofilm technologies rapidly, continuously evolve, will the traditional, classic clinical signs of overt infection that we heavily rely on today simply vanish entirely? In the near future, we may be forced to rely exclusively on highly advanced molecular markers and artificial intelligence-interpreted PT-CT metabolic patterns long before a highly vulnerable patient ever spikes a fever or develops a concerning positive blood culture. How will this fundamentally completely change our basic clinical definition of infection on the wards when the highly complex pathology is definitively identified at the microscopic metabolic level months before any systemic recognizable physiological response ever occurs?
That is a profound, highly complex clinical paradigm shift that we will all have to carefully navigate in the coming years. Thank you to our fellow physicians for joining us on this exhaustive, highly rigorous deep dive into the complex management of endovascular and graft infections. We deeply hope these extensive clinical insights directly inform your specific diagnostic and therapeutic strategies when managing these critically ill patients on the wards. Until next time, keep questioning the emerging data and continuously refining your clinical practice.